Good evening, everyone. My name is James Jimmy Hills, and I'm the host of Java with Jimmy and also the segment Your Healthy Java. As you see, we are here with guests tonight. I'm going to ask you to do me a favor, and we're going to do this on the platform, we do stuff authentically, organically, in real time. So we all have our phones, and so we're going to go retweet and share on Facebook right now. So do me a favor. We are acknowledging and kicking off Hispanic Heritage Month this evening, and we're talking with some great folks from Massachusetts General Hospital, and we're going to have a very real We're going to have a very real conversation about health, about culture, and about disparities, and how there are similarities with Black and Brown patients, and how there may be some uniqueness, but how we come together and also advocate and work toward policy. So do me a favor, like we're doing here right now. Go to Twitter or Facebook and just hit retweet, and we're all set. And somebody please turn my phone or the computer or something down somewhere that's live. All right. I am going to get ready to introduce my guest and give some context to why we're here today. So as I said a few minutes ago, today is the beginning of Hispanic Heritage Month. And when I was talking with Dr. Alabre, who we talk often, we wanted to acknowledge it, but also the Office of Equity and Community Health does a lot more than partner with and support Java with Jimmy. And so there's sort of a similar platform that's done within the Latino community. And so we wanted to cover that as well. So without further ado, and I'm kind of old school, so I'm going to ask our wonderful ladies to introduce themselves first. And we'll start with Dr. Kareen here on my left. Please introduce yourself, and maybe in your greeting as a little icebreaker, tell us how you would describe Black and Brown medicine in 2022.
All right. So hello, everyone. My name is Kareen Davila. I am a palliative care physician at Mass General Hospital. And let's see how I would describe. So I would say there's an ever important need to be focusing on helping all of our Black and Brown patients, because I think we know that there's a wide range of disparities that exist across the age and health and illness spectrum. And so for me, I work in palliative care, so I help a lot of people who have serious illness.
And palliative care, for those that don't know, are senior citizens.
No, it's actually not. It's actually not. Let me tell you a little bit about what palliative care is. So palliative care is a specialty of medicine that helps people with serious illness. And that's at all stages, from the time of diagnosis all the way through the end of life. And so we really help in three main ways. First, around people having symptoms like pain, nausea, things like that. We help support decisions that come up over the course of illness and helping people and families think through how to make those decisions. And then really just being an extra layer of support for patients, families, and medical teams taking care of them.
So thank you for the clarity, because I automatically thought that was more of a senior care. Yeah. And maybe because seniors tend maybe to present for the majority with those type of symptoms or complaints. But
I think that the older we get, the more likely, just with time, to be ill. And palliative care often works with geriatric medicine. So I think what you're describing is really geriatric medicine that helps older adults.
Okay. Thank you so much.
But palliative care, you're right, often overlaps and cares for some people, and that can receive care with both. But palliative care is its own specialty and a little bit different than just geriatric medicine.
So we're learning a lot of new things tonight. Gladys, please introduce yourself. Tell us a little bit about yourself and how you would describe Black and Brown medicine in 2022.
Thank you. I'm very happy and honored to be here. My name is Gladys Pachas. I am the program director for the Center for Addiction Medicine at Mass General. I've been working there for a bunch of years. Now, your question makes me think about inclusivity. And to really talk about inclusivity means to talk about access. And access means healthcare being accessible to everyone, no matter age, ethnicity, race, gender identity, sexual orientation, to everyone. But not just only access, also respect. And respect of our differences, respect of our similarities, respect of who we are, feel empowered to really show who we are without being afraid of being not respected.
Dr. Labre, I think Gladys is going to give us one of those moments, and we'll tell you all about that later. But please introduce yourself, Dr. Ephraim.
All right, so I'm Ephraim Flores. I'm a radiologist here at Mass General Hospital.
We're not at Mass General.
Oh yeah, sorry. I had to. Like my automatic replies. I'm like an autopilot. So
just imagine this is the.
I know. We're here at Dudley Cafe enjoying incredible food and better company here as well today. And then just wanted to say that how I would describe Black and Brown health in 2022, it's empowering patients to take control of their health. And that's what we're all doing here today.
Absolutely. Absolutely. I thought you would go a little bit deeper, but I'm sure as we talk, we'll hear more. Dr. Labre is no stranger to your Healthy Java, but for those of you that may be watching for the first time, Dr. Labre, please introduce yourself. He is our medical director for your Healthy Java. Introduce yourself and tell us how you would describe Black and Brown medicine in 2022.
Sure. So yes, hello everyone. And for those who haven't seen me and heard me, I am Dr. Claude Labre. I'm an internist at Mass General. And I've been doing this sort of health education, Your Healthy Java with Jimmy for almost a year now. It's going to be a year in October. And so we are doing our best to try to hear what concerns, questions people have in the community and do our best to help answer those and bring understanding to the state of medicine in 2022. And so how would I describe medicine for Black and Brown? I mean, the one word that comes to mind is, as we've sort of mentioned, is disparities. It unfortunately is still a problem. There is still lack of access, even differences in delivery of care, even with the knowledge and understanding that there are disparities. But the good news is there's been a lot of work being put into solving this issue and reducing the disparities. Part of what we're doing here is to try to bring knowledge, because knowledge is power, to people who may have not had the proper access and proper care for one reason or another. And so we're doing our parts in the MGH Equity and Community Health is fully committed to bringing medicine to the people where they are. Hence our presence here in Dudley's Cafe, because we understand that it's not just the people coming to us. We also have to outreach and help and hopefully bridge that gap in 2023.
Yes, that was good. I'm like,
the year's almost over. I don't know how much time we have left, but obviously it's a work in progress. There's a lot more to be done, and we certainly are committed to doing the work that needs to be done.
One of the things that is interesting is none of you, the four of you as physicians, you're not technically a part of the Office of Equity and Community Health. Is that like true, or you are? Okay, so go a little bit deeper. I've talked to Dr. Labre, and I know from his perspective, and as it is Hispanic Heritage Month, how, Java with Jimmy primarily targets to the Black community. And so there is sort of, we talk Black and Brown, there's a Latino community as well. And so how does the Office of Equity sort of engage the Latino community as well? And then we're going to talk about similarities between both populations and where maybe some of the disparities, not just the disparities, but the results of some of the diseases or things that ail us, where they may differ. I'm sure there's a lot of similarities, but maybe either diet or region or whatever, there may be some differences as well. So anyone can jump in and sort of, from your perspective, how are things going, and why do you feel that equity has made this investment in Black and Brown medicine?
So going back to the pandemic, I would say.
That's what
that we learned a lot,
right?
And so one of the things that we saw at the beginning of the pandemic was that about 50% of people who ended up in the ER with common symptoms didn't speak English. And that was the reason why a group called was in Spanish
The
language care
Ernesto
group.
Gonzalez Spanish language care group was
Okay.
formed.
was formed, and it consisted of about 60 to 70 physicians, speaking Spanish physicians, who participated in the care of.
Was this just MGH or across the city or
We
state?
started it.
Okay, you see that? We started it, MGH.
By we,
yes.
MGH.
And then, I know in Salem and the North Shore also, they were using kind of the same model, but we began using, leveraging all these resources that we had to make care better, to take care of these patients better. So after that, I think that was the beginning. We all were there participating in this group. It was mostly on a volunteer basis, but it was, it was sad because of the pandemic, but it's also great how the community got together really to take care of this. After that, we kept on working with the community. So we are now part of the Equity and Community Group, and working in different places. We are partnering with El Mundo, El Planeta, which are newspapers
We're definitely
and
going to
social
talk about
media
that. Yep.
in Spanish. And we have a similar educational and communication program to really talk about important health aspects. So like, for example, we have, this month is the recovery month. So we're going to cover some of the recovery aspect of substance use. It's things like that.
Okay. Your perspective from what? Okay.
Yeah.
Let's go again. Ladies first. Go ahead.
Ladies first. Go ahead, Karen. Go ahead, Karen.
No, I was just gonna jump in and add that, not only was the Spanish language care group helping with kind of, I would say, direct patient care, but there was really also an emphasis on getting reliable health information out there. Because I think especially early on in the pandemic, there was a lot of uncertainty. We didn't know a lot about this brand new
People
disease.
with melanin couldn't get it.
There was a lot of misinformation
Yes.
out there as well. And so I think one of the things that we really tried to do with, the Office of Equity and Community Health is really try to get good, solid information out there, available and accessible to the community. And so, us and others, participated in recording, little snippets of like, what does it mean to socially isolate? What should you do if you start getting symptoms? And little things, in both English and Spanish to get part with our partner media outlets and get trusted information out there from a physician who looks like them, because often that makes a real difference.
And that's one of the things that is so often come up, and if I'm going to come to you, but that is one of the things that I love about the Office of Equity and Community Health and Dr. Alabre. And I'll be very honest, one of the things that Dr. Alabre is faced with, and I'm sure maybe in your segment as well, is that there are certain specialties where there isn't a large cadre of physicians and providers that are available that look like us. And so I think that that's important to name, and it may go to the fact of how we start getting this next generation. There's been a shortage in nursing for what, 10, 15 years or whatever, so anyway, Office of Equity and Community Health.
No, I just wanted to say, I just wanted to add to that both points that Gladys and Corinne had mentioned is in terms of misinformation, disinformation, and also how to combat that, because it's our community are getting, during COVID, we saw that that lack of trusted health information was not getting to our community. So the problem when that gap opened, disinformation and misinformation filled that gap, and that resulted in worse outcome for our patient population. So the whole purpose of some of the work that we're doing, for example, working with you and through the Equity Office in other mechanisms with providing information, and not only from credible sources, but credibility is built on trust. And trust requires a longitudinal engagement and longitudinal relationship. So, I'm here in Dole Cafe, I'm looking at the plants outside, the plants here. And when I think about the drought, right, so the plants require care, they require watering, right? So when we plant them, it requires a continuous engagement with them. And the same thing with the relationship that we're building in the community. It requires that continual engagement and that continued presence. So the plants can be beautiful as they are, and then we have a great relationship like today that we have the opportunity to share with you. But in the end, it's about being with our patients through that health journey, from information to helping them connecting with the health system, also helping them in the time of need is meeting patients where they are, but also when they need us. And COVID just showed us that there's a lot of patients that are in care, in need of receiving care, and we want to be there not only in this moment, but also to build that better future together.
It's so interesting. I love how you framed our, because when we say Black and Brown, there is a community. There is a difference sometimes because part of the Black and Brown community can speak a different language. Even within Hispanic or Latino community, there's different subsets. But I always believe in this adage, we do better together. And when it comes to addressing inequities and advocating, I think that we do, like if you saw the two of us on the street, folks would think that we were brothers versus being of two different quote unquote races or ethnicities. And so I just wanted to name that. We're going to get into a little
also,
Go
just
ahead.
to add one
Yeah,
thing
come
there, I know we sort of mentioned the differences in how people look, but there's also the background, the history. And this is part of why we're sort of doing this Hispanic Heritage Month. What
Yes.
does that actually mean? And because the lived experiences that we've mentioned so many times on this platform is that it does matter, knowing that background, the history behind it, and being able to connect
Yes.
with the patient, not just on the level of medicine, illness, or language, but also shared lived experiences. And part of the issue we had with trust was that when the pandemic first started, again, going back to that same example, there were people who were just viewed as hesitant. But why? So until you
Start
dig
to elaborate.
deeper and figure out why were people hesitant about the vaccine, if you never had that experience or even heard about it, it's gonna be hard. And you just see that person as someone to disregard, who just doesn't get it, is not educated, and all kinds of things
Yes,
can
yes,
come
yes.
up, when all it is that they have reasons to shy away from something they don't know that might have hurt them in the past, that has a history behind it. So celebrating history is key to every aspect of life, including medicine. And we have really learned that until you understand the history, you can't really move forward and provide adequate care, since this is sort of mostly focused on care. And we have to do it.
It's interesting. Gladys was shaking her head, and Karine as well. When you said 50%, I automatically assumed that you were going to say that 50% of the folks in the ERs were Black and Brown. That's one sort of kind of what you're talking about. That's one sort of perception that, you know, if there is some biases by appearance, that's one bias.
Mm-hmm.
But then when the person gets ready to open their mouth, and a provider that may not be of that, you know, experience, is there an added layer of bias that a patient that speaks another language, not just speaks another language, but can't speak English clearly, is there another bias that comes with the appearance, along with the doctor or nurse may feel I can't communicate with you without a medical interpreter? How does that play out?
It's difficult because you have, for going back to COVID, right?
Yes.
COVID patients who ended up in the ER were gravely ill,
Yeah.
right? And they are desperate, they're scared, they don't know anybody, and they don't speak the language. They can't communicate, they can't say what they need.
And they're alone.
and
They're
they are
not
alone.
with a family member who is maybe
Because
they
an
were-
interpreted
They
role
were not allowed
for
to
them.
come in. So I had
Hold on. That's kind of that's just interesting to think about somebody in that situation.
I had, when I started working with the group, I worked in the ER as well. And several times, like working in the ER, seeing people alone, crying, desperate because they couldn't, and the interpreter services wouldn't be enough because there
were overtaxed.
There was too
number
much
was big.
need.
There was a lot of need.
Yep.
And, going there and really talking with them, just holding their hands and say, it's going to be okay. It is going to be okay. Right? In your own language, with your own culture,
Yes.
maybe joking around,
Yes.
joking about things. But we didn't even talking about medicine. We were just talking.
So is that the end? In that situation, that was terrible. But in a proactive planning, is that the end within different communities, not just Black and Brown, Southeast Asian and other community, marginalized communities, not just race and ethnicity, LGBTQ, trans. So go ahead.
So much of medicine, I think, has become, and this is the way we're trained. So, you can't blame folks. You're trained about problems, health issues. You're trained to treat the problem. And what we really have to do is take a step back and remember, you're not treating a problem or a set of problems. You're treating a person. You're treating a human being who fundamentally just wants to be treated and respected like a human being. And so much of it is just being in there, walking in, being real. How are you doing today? Oh, I'm sorry, you're in the hospital. You don't want to be in the hospital. That's, I understand you're not really having a great day. So almost you have to reframe, maybe how are you doing today isn't even the right question. Yeah. But connecting with them and remembering them and coming in, if they're talking about.
If they can understand you.
If they can understand you.
Let me tell you one experience that I had. I always tell the same example because I think it's fascinating.
Gladys is. I know Gladys hasn't been on before. Go ahead.
Gladys has been on other places.
Oh, okay.
He's saving pearls.
So I was in one of the floors, and we had this Latinx older woman. She was sick, very sick. And the nurses were complaining that she didn't want to drink any water, right? So I went there to see her, and she didn't speak any English. And so what's going on? Why you don't want to drink any water? And she's like, well, it's because the water is cold, and I have a problem with my lungs right now, so I can't drink cold water. She couldn't, and for some people that that is very cultural, right? Yeah. That is very cultural. That you can't, if you have a cough or some respiratory symptoms, you are not going to be drinking cold water. That makes sense for her, but she wasn't able to communicate. So I told one of the nurses, can you please bring some warm water? She's going to drink that, and they brought that. She started drinking. So that's so easy, just because of the language.
And I have
communication.
I just wanted to say that there are two things. One is that when you're talking about that and sharing the story about COVID, it reminded me my mother was in the hospital for COVID, and then a few months later after that, the only thing that she kept talking about, more than just the symptoms, was the loneliness that she was feeling. And I think that that's one of the key things from COVID is that a lot of people felt alone.
Yeah.
So sharing the cultural identity or similar background, what Claude was mentioning before, it's really critical for us to be effective in our work, because at the center of equity, it's empathy. So sharing that cultural background or those experiences or similar, it doesn't have to be the same, allow us to put ourselves in more than patient people, right? So Karin was saying we take care of people. We're not saying patients. The patient thinks about a health problem, but we're here taking care of each other. We're working together and taking care of people, and allowing us to put ourselves in those shoes, to walk together and see how they're experiencing care from their perspective. And our systems tend to be built on systemic barriers, and then the way that we talk about people in healthcare tends to be punitive against the patient, right? So we talk about, Gladys talking about patient with the team would say, well, the patient is non-compliant, they don't want to take water. But it actually a slight change in that reframing the perspective and and words matter, right? So our care starts with how we talk to our patient, how we talk to each other, and then reframing that, just putting ourselves through the patient's lens, understanding their cultural background, saying, the patient doesn't want to take the water, they want to take warm water because of past experiences, what they learned growing up, and there are many instances that we see on our daily basis. So our goal here is to not only disseminate information, but also gain the community perspective so we can deliver better care.
And that's so interesting, because Dr. Labre and I, we often sometimes feed off the comments or answer questions. And that is sort of the liaising that one of the reasons that we have both of these sort of streams of support and intentional reach into Black and Brown communities. Tell me a little bit about the collaboration with El Mundo and El Say
El planeta.
el planeta. Did I say it right? I'm gonna learn some Spanish today.
There
Se
you go.
habla español muy poquito.
You see this?
Habla español. That was good.
So
Tell
we-
us about that
So I can
collaboration.
start, but I mean, we all participate here, and this is thank you again to the Equity Office and Dr. Joe Betancourt, who's been a leader in this and spearheading not only the effort, but like truly the relationship
Yeah,
in the community as well. So with what started with COVID, understanding like how do we disseminate information in the community about, Karim mentioned earlier, preventing COVID infection. If you get COVID, how to
I see.
where to get care, or like when the vaccine was coming up, why we should all get the vaccine. But then we wanted to better understand how do we leverage those established relationships to build that, use them as pillars to build that better future together. And so that has evolved into, for example, in Mundo we'll have we have a every other week we have a what they call the El Minuto de Salud, which is like a healthy minute.
A
with them.
minute?
Well, it's not a true minute. But
We got a whole. I bet you can give you at least the whole.
it like you know,
It takes a minute.
it's a very short. It's a very short segment, but we'll have a lot of Spanish-speaking, like Latino physicians, Corinne including myself, Gladys, and others that from MGH that participated there and talk about present issues or health topics in the community. So, for example, Gladys was talking about the upcoming month of substance use, like in October, Breast Cancer Awareness Month, they coming
Yes.
around the clock. Now with the start of school and people with the children talking about COVID vaccination or like flu shot.
Colds.
So and
germs.
cold and what to do, and then
The
we had a
kids.
pediatrician. So and then we were using the multimedia mechanisms to disseminate the information because we want to be there for patients whenever they're ready to engage and or they're seeking that information. That will be the credibility from trusted sources needs that continuous presence in the community.
Any other input there? And then I want to ask, and anybody can jump in here too. Why now? In the first couple of stages, first couple of episodes of Your Healthy Java, Dr. Labre and Dr. Betancourt, we have to say a shout out to Dr. Betancourt if he's listening or watching on Twitter. Can we just give Dr. Betancourt a hand? We really do have a live audience here. But they were very honest and real about, medicine in general. And then they named that Mass General, may have, some interesting history that you pointed to. Why do you all, and jump in, why do you believe now that it's become a priority for the investment to be made in Black and brown media platforms, in dedication of funds to do certain things like this? We have a health fair coming up. Why now? What happened? Was it COVID? Well, you say why not? But and I'm with you around why not, but we were why notting 15 years ago.
Mhm.
Yeah.
So why do you believe now that there's this sort of assertion and aggressive in supporting this? DEI has become such a sexy buzzword, but why now? Anybody?
I really do think it was the pandemic.
Okay.
I think really all of the underlying structural
That we
problems
were aware of. Yep.
have been there for years to
Magnified.
centuries, but nothing like a pandemic that affected everyone disproportionately. mind you,
COVID was
but
not racist. Or
affected everyone. Like I said, disproportionately to Black and brown
Well,
communities, but
mm,
to all of a sudden have everybody sit at home and could watch the news or see, and all of a sudden these differences were magnified and people were forced to face it in a new way that I think, some were just not, it wasn't their biggest priority until they were forced to look at it.
I like how you balanced when I said it wasn't racist, but then you pushed back and said, but it was a disproportionate impact. And it comes from what we know and saw. This exacerbated what you all know in public health around social determinants of health and things like that.
Yeah.
So maybe let's go a little bit. Did you want to add to the why now? You just simply said why not. Why did you respond like that? Gladys got a lot of moments. Oh my goodness, I'm enjoying all of you, but Gladys got a little.
So I just think that because of the pandemic and because of the things that we realized, we really tried to understand, there was also some infrastructure that started to form, right?
That's a nice way.
Like the Spanish language care group started to form.
Oh, yes, okay.
Yeah, that people trying to help the stations of MGH getting together and trying to help the community. So that we're looking for a continuation of that effort and make it more. I don't know if the official is the right word, but make it sustainable.
Yeah.
Right. And the way we're trying to understand how to make it sustainable. We don't want this to disappear. We don't want just because COVID is going away or is going to stay chronically, just we are going to forget about the community. No, it is actually the opposite. Now, okay, COVID. What happens after COVID? Now, do we have to really promote preventive care, like mammograms, PAP, all these things. So I think that's why we are putting together. We are really excited that we have people that can help, that can work on this, that want to work in the community and try to promote that.
And also, you wanted to briefly add that I think what COVID did, it just really put a magnifying glass, and more than just magnifying glass, it's just understanding the direct relationship from what we call the social determinants of health, which are the conditions outside where we live and work and raise our children, and how those social determinants of health directly impact your health. So, and in this case, in COVID, for example, we think about living in overcrowded housing, how that increases the chance of spreading disease. If you don't have access to a primary care physician, how that prevents patients from seeking care in a timely fashion, or when you're working in a job that you have to work 2-3 jobs and can't take time off because you don't have enough sick leave to go and get care, and you don't have those benefits, and how those factors come into play and resulted in patients directly getting worse, suffering from worse outcomes in COVID now with the severe disease and everything. And so we were seeing that, so that it made institutions take a step back, not only within COVID, but like we can't go back to usual care.
No.
That's not really, we have to make a commitment to say, how do we build that healthier future? And that requires that investment in the community through these processes and more, because our work doesn't end with equity. And the ultimate goal is to achieve social justice. And the way that we do that is to working together and making that through commitment.
You can clap if you want to. I mean, because I mean,
we are on the same boat.
but even that statement,
No.
oh my
No.
God, I'm going to break that down. But go ahead.
So I want to add, and Efren did just such a beautiful job right there of kind of tying the impacts of the social determinants of health that have on direct healthcare. But I think us in public health often take a step back of like, yes, that's the downstream impact that we see in front of us, but we have to start looking further upstream. It's not all about the social determinants of health. It's what are the structural determinants of the social determinants of health. It's taking a step back and recognizing that change has to be made on multiple levels. It's not just the person in front of you. It's why were Black and brown people disproportionately affected by COVID? Well, they disproportionately have asthma, COPD, other lung diseases. Well, why? They grew up in areas that have more air pollution than other areas. And all of these things go back to choices that take us back to redlining and so many other things that we can just keep going. But it's all about thinking about the big picture and recognizing, yes, as physicians, I think we're trained to most treat the person in front of us.
Mhm.
And that's important. Direct patient care is important. But public health arguably has a bigger impact, and we got to think bigger.
That's why part of the language when I was talking about what we were going to do tonight, I want to spend at least 5 minutes toward the end on this, is we do better together. And so how beyond your healthy Java every first and third Tuesday, I'm appreciative of it. But how do we get into policy around those systems and structures? Because I often have to remind healthcare advocates, substance use providers, there's one goal: to equitably improve the quality of life for everyone. And I like what you said. So to equitably improve the quality of life for everyone through a social justice lens, that healthcare, helping people, that is the real, to me, that seems to be the ultimate goal of an equitable quality of life for everybody. I wanted to go back when you said we're all on the same boat. It's so interesting because when I was younger, to me, Black and Latino, all the same. There's a term that one of our city councilors always use, and if I say her name, you will know what the term is. Julie Mejia. What is the term? How does she describe herself? I'm sure you may have heard it before. You may have, because you're smart. She often says, I'm an Afro-Latina. You know what I mean? And so when you talk about the boat, I remember being younger, and when I learned about, slavery and whatnot, and I said, there ain't no difference between us. Boat brought us all over from Africa. It's just that the boat in Puerto Rico broke down and the boat that broke us. You know what I'm saying? So we really are, in a sense, in the same boat. So maybe let's move into the space around. First, let me ask.
Let me change that then.
Go ahead. Upgrade.
So going back to the theme for Hispanic Heritage Month
Yes.
is Unidos.
One.
Right?
Unidos.
United.
I was close. Okay. Uno. Okay. Go ahead.
Yeah. And to me, United is seeing this not just about you don't like the boat. Okay, let's change the boat. As a human body. And the human body has different organs and systems that with different jobs and different characteristics and different talents. And all of these are unidos together to form one person.
Many members, but we got some preachers in here.
I didn't finish.
Oh, sorry.
Glad you're the fiery one.
Listen, I love it.
If we don't take care of the entire body, meaning everyone, what? It's true. Because if your hand or your finger is sick or your little toe falls off, you're not going to be able to walk. You have to take care of that. And every part of your body has the same right and has the right to be listened to and respected.
So I mean that I think that covers the similarities around culture. Are there differences between Black? I'm just going to go ahead and turn this over to Gladys. Let her take over. One of these days, if we take a vacation, we'll show Gladys how to sign in, and she can do your help.
You can do it. Yeah, absolutely.
That might not be a bad idea to have that.
You never. Yeah.
Are there differences with Black and brown when it comes to demonstration of the health disparities? In the Black and brown, in the Black community, you hear diabetes, high blood pressure, asthma.
Sickle cell.
What is it? Sickle cell. Absolutely. What are the top sort of demonstration of trends within the Latino Hispanic community? Is it the same? Similar.
There's a lot of
Yeah,
similarities
I
in
would
terms of
definitely a lot of diabetes,
Diabetes.
high blood pressure,
Yeah.
kidney disease, asthma.
Is there any obesity? Well, again, we all on that same boat still. So there really isn't that much.
But I will say, I think there's definitely ways that we're taught in medicine. And I think one of the challenges is that there is so much medicine that one human can't possibly learn everything there is to know.
Right.
And so we learn in pattern recognition and trying shortcuts to, like, when you see a certain set of symptoms, you're trained to think about a certain disease. And oftentimes that does help you, right? That helps you process information, that helps you get to the most likely answer faster.
Okay.
But it's not always true, because again, you have to treat the individual in front of you as a person. And people don't read the textbooks of how you're supposed to present when you have the classic presentation of diabetes or the classic presentation of sickle cell or something else. And, sickle cell, as our audience member here shared, is an example of where there is an increased prevalence in the Black community, for example. There's also, I think it's less known, there's an increased prevalence in the Middle Eastern community for sickle cell. And there's other, remember, no single human is a single pure race or a single pure ethnicity or many people. You know, we've been on this planet for a long time, and there's a lot of intermingling going on. And so,
Same boat.
Same body, same
and I
body.
think one of
Same
the
body.
things-
Same boat. Same
One
body.
body.
The challenge of using those shortcuts is that sometimes they can lead us astray. And sometimes, you know, we've seen, or there's a story of a young Hispanic individual who presented with symptoms that if a young Black individual had presented with those symptoms might instantly be thought of as sickle cell. And that young Hispanic individual took a lot longer to diagnose their sickle cell because it wasn't the first thing they thought about.
So from a perspective of ruling out, that's one of the terms, you know, that people use. And if they really are working, if physicians are really working to rule out, that they're going to exhaust every sort of screening, CBC, X-ray, CT, all of that, to rule it out. And so it's so interesting to hear that, one, sickle cell is prevalent within the Middle Eastern community, and two, to on one hand, know that a person would not get the proper care, because you've talked about training often, that
Right.
it does start in school. It does start in school because the textbook,
And one of the things too with what Corinne was saying there is that we are also learning that a lot of the things that were ascribed to just race are actually not race dependent. They actually, those social determinants of health, or those backgrounds, those structural disparities and everything else. And so we now have to realize, well, just because someone is Black doesn't mean they're going to have all those diseases we learned that actually were more prevalent in Blacks, or that the Hispanics and the Blacks actually share a lot of those we were just mentioning sort of diseases that they're seeing more, like diabetes. And it's not because of genetics. We used to just say, oh, it's just genetics, but it's not actually. It's because they have shared experiences. They lived or are from similar areas, or social status, I meant to say, in terms of either being immigrant or having language differences where their care actually were not as appropriate, or access issues. And so they end up with the same diseases because of these factors, not because they were actually dissimilar genetically speaking, that the body is different. It's just because how they were treated, or how they grew up,
where
they lived, and all these other factors. I mean, there's a list of them you can list. And so we are learning more and more, even in medicine. Towards the end of my medical school, we were starting to learn that some medications work better for certain races, and it turns out that wasn't actually quite the case. And so we have to stop ourselves and not jump to conclusions when it comes to races, and think, what else is there? What else are we looking at? And so that's somewhat going to revolutionize, I guess, in a sense, medicine and how we approach and categorize people and put people in those
undoing
Yep.
the legacy of racialized medicine.
Right.
So there's a lot of movement in medicine in terms of anti-racism and de-racializing medicine, as Corinne was saying, because it just perpetuates the current structural barrier that we're having. So, we're just having the conversation on this share of idea. Imagine if we only had a one-on-one, we'll be missing a very rich conversation. And that's what happens when we are not working together, that we miss the rich perspective, the better care that we can deliver. Really no more than just one body, really in that emphasis, that impetus to do work together, and it requires all hands on deck, and it really to put us together, because heavy lifting, which is like de-racializing medicine, overcoming the structural barriers, requires many hands, right? So if we lift the table, if I do it one hand, probably I won't be able to do it. But if we all do it together, it becomes a very light lift. So that's the same effort that I require among all of us to really work together to achieve that goal.
Do you feel that this is making its way up to corporate? Again, we have folks like Dr. Betancourt is vice president at MGH. I know his advocacy and whatnot. Do you feel that it's because medicine, I remember when I was in ER at Children's, it was the beginning of the HMOs. And even in I think at that time, in my late 20s, I started thinking that medicine is becoming about money. And so I know sometimes at the corporate level and, quote unquote, the big wigs, sometimes it does come down to the dollar. Do you feel that, and I'm not saying this, I'm saying this as a macro corporate level of medicine, do you feel that this mentality and this perspective is making its way up, either through people like yourselves being promoted, or just by the reality of people in those positions seeing COVID? And how do you all feel at the upper sort of corporate level, how that generally in medicine, not MGH,
right,
but generally?
It is making its way. I mean, just the existence of the office alone, I mean, that takes money. So there is fund dedicated to this kind of work, to undo those injustices in a sense, or at least try to work towards that. And so we know money matters, money talks. That's always going to be a reality. And part of it, and that's why we now talk so much about equity, and that we are able to justify putting so much money into those efforts, because we know that it wasn't these people's fault that they are where they are, and that there are lots of the factors or the reasons why they got there. And the only way for them to get out of there, it's not their responsibility to get themselves out of where they didn't actually choose to be. And so when it comes to equity, when we talk about equity, is that we are somewhat doing unequal things, but the unequal thing is to bring equality by putting the money in the fund into the things that were done years ago, over centuries. And so when it comes to this, I think it is making its way, and a lot of people have obviously fought for many years to try to bring it first awareness, and then understanding, acceptance, and now actual action, and say, we gotta do something about this. And so we're getting to better places.
I like your point, Claude. And one thing I want to mention is, you know, you talked about how it wasn't their fault. And I think there's, unfortunately, sometimes how we describe, or a friend mentioned this earlier, how we describe individuals can sometimes feel like we're blaming them for their circumstances, which is really a problematic framing. And so oftentimes, especially during the pandemic and such, you know, we talked about this question of mistrust, and it kind of made it seem like, you know, well, there's mistrust in the Black and Brown communities is maybe the reason for either being hesitant about vaccines or hesitant about seeking care. And I think again, this is kind of the reckoning that's happening in medicine that needs to continue happening is medicine, and I'm speaking broadly about medicine over decades. Medicine has not given Black and Brown people, they have not been trustworthy. Trust is earned. Like, you have to be trustworthy to earn that trust. You know, you can't say it's your fault, you don't trust me. No, you have to show up day in and day out and earn that trust.
No, I just wanted to, Karine is saying, it really hits a nail in the head, because it reminded me when we were first talking about the community messengers initiative. People were talking about trusted messengers. That was the initial first name. But then trusted messengers, without being out there in the community, without doing that trust building process, without doing those, putting the effort in those bridges of trust, it's a big assumption. So that changed it to community messenger. Sure, we've been in the community, we say we're trusted. I would say it reminded me when we're not there yet, we're definitely moving toward that goal and working together. I remember when one of the first events, when we had the community messenger ban, and people saw the ban and we were not sure because we didn't have that long-standing presence. Several months later, or a year later, we were at Nubian Square at the Christmas event, at the parade, and the people were approaching and asking, and then they say, when are you coming next? Right? So that they were asking already, that they expect that relationship. So we were able to say, oh, so this is the schedule, refer to that. So it changed from not knowing who we are to asking us, when are you coming back?
It's
right?
That
consistency is required. But then, one of the things that also, when you're talking about the investment and why, I tell Dr. Betancourt that, by leading all these efforts, he saved so many lives, especially during COVID and everything. And I said, at some point you gotta take a step back and realize, many of these initiatives wouldn't be possible if you and the team that you have, not only including Julia, Esteban, and everybody here, giving us the opportunity to do that. But in this line of work, sometimes, I'm not saying we're fortunate to be in an institution that we have leadership commitment top down to do this work. Sometimes in this line of work, there's some opinions and there's some feelings that may not be fully in line with that. So our goal is not only to do the work, but also document it. How we tell a story is like keeping data, showing it, being transparent in the process, because if we don't do that, then we can't come to I will never be able to argue against feelings and emotions. But when we have data, we can come to a common ground and have a conversation that is objective and then build up from that on what the next goal.
It's interesting that you say that you attribute, the saving of lives or impact from Dr. Betancourt. I was very hesitant in the beginning about the vaccination. I was good until something happened with Johnson & Johnson. And I was like, nope. And if you all watch, Java Cafe, you know the name Thaddeus. So he's like, you better hurry up and go get that vaccination. And I wound up flipping and changing and getting the vaccination and became an advocate because I understood that the more people get vaccinated, the more I can start going on vacation and going out. But in talking about...
It's all changing behavior just begins by asking your why. Find the motivation.
Listen.
And you can help.
So, I mean, people have inboxed me and said more than a couple, I got the vaccination because the city wound up capturing it in the health commission and whatnot. But we were talking about it, and I was keeping it even in our conversations. It was still sort of coming up Delta or Omicron and Delta Omicron, Delta Cron, and we were still talking about the vaccination and trying to get people to not be so hesitant. So I need to say that you are absolutely right. I know of some people now. Did he come in and give them what do you call it? Resuscitate them? No, but the support of this platform, the education from Dr. Alabre and the people that have come on, it is having an impact and change. A lot of it is, when you talk about data, a lot of it is anecdotal. It's conversations, it's comments on the stream, it's the questions that people ask. Speaking of questions, I do want to get ready to I can't believe that an hour never goes by. Well, sometimes it does. It never goes by that fast when we're virtual.
Not as fast as today.
This is so much different to be able to have this conversation, sort of, as we said, move away from the Zoomness. But I really, really appreciate the impact that we've been able to have through these conversations. And even today, I think somewhere along, I believe on Twitter or wherever, some other providers are watching. It's not just about education. I'm just getting this. It's not just about the education for the patients. Mm-hmm. There's some level of education that we're doing of providers. And, maybe some of the big wigs are watching or whatever, and really understanding that the equity and the diversity has to take place at all levels.
That's how you get to stigma. It's all these...
Say that again, Doctor.
That's how you get to stigma.
Yeah. And stigma is not a bad word. It's just you want to create...
on the part of the providers or the physicians and doctors who will be faced with that person and already have a set of ideas of what they're going to say, how they're going to act, how they will react, without any understanding of why. And so
back to kind of a little bit different, but what's the why?
What's the why? Many physicians want to be able to reach the community, but they don't know how. And I had several people asking me, so I want to go to Chelsea, who I can talk with, and to set up the path, to set up the network.
Yeah,
so we can actually do that. Again, talking about sustainable, right?
Sustainable.
So make it this effort to be sustainable, forming networks of. We're working in communication and education, so making these networks of physicians that can go into the community, find out what they want, what they need, and based on that, create the programs, the educational programs, and really increase knowledge, right? So the way how people are able to make their own decisions, to empower them to make their own decisions in terms of their health, is giving them knowledge. Right?
Informed and educated decisions.
And I want to go back to a thread that you started with that I wanted to kind of come back to is continuing to go and show up in the community, because not only are you impacting the people who you're touching, but you're impacting the future. The presence of a Black or brown physician coming to the community and showing up and showing that little kid, this can be you one day.
Yes.
It makes a real difference. I mean, my own story is one of representation. I wanted to be a doctor since I was 6 years old. Why? I moved to the Atlanta area, met Dr. Gadea, a bilingual Latina woman who looked like me, who could talk with me and my parents, switching English and Spanish of like what, when you lose the thread, you switch to the other language. Can't remember that word, go on. But I didn't have physicians, or people in healthcare in my family, but I saw her and I was like, I like you. I want to be you when I grow up. And so that matters.
Yeah.
I wanted to add that. Go ahead.
I just real quick. That's why I have this here, so people can see that I speak their language.
Yeah.
And I
If
said,
they're lost in the pipe, well, no, I'm sorry,
for
wrong
real. I'm
building.
looking at MGH
Yeah.
in the hall, and I think people talk to me just because it says
They
that I
know,
speak
they feel
Spanish.
safe, in a
Exactly.
sense secure.
Exactly.
Interesting.
No, you wanted to add briefly to what Corinne and Gladys is saying that those relationships in the community can't be transactional, right? So it's not like you're going into the community expecting to either do a project or like I'm gonna do this event and then expect that. You have to do it because it's the right thing, not expecting anything in exchange. You're doing it to pay it forward, to opening up doors for the next career, to also provide that better, more opportunity. To open up the door for the opportunity that we have, like things that we have in the system that we want everybody to take full advantage of it. And we're putting ourselves out there in it because the problem is that we operate in a way that we do something, we expect something in exchange, but then we can't, that doesn't work in the community. That's not how you build trust. That's not how you build empathy. We have to be, because in the end, we're all patients, right? At some point, I'm going to receive care. You're going to receive care. Everybody here are going to be a patient as well. So how do we need to really center ourselves and say, not how do I want to love, of course, my mom, but also how do I want to be treated as a patient? And then that's how I should be treating people.
Another way to increase trust is to actually listen to the community, listen to their needs, listen to what they want. Because many researchers, for example, want to go into the community to
qualify or quantify what they already think is their hypothesis or whatever.
Yeah, or to just recruit people, right? But what do they give to the community? Are they even listening to whether they need this or not? We're trying to do that actually. But that's one of the ways also to listen to the community, not because we know everything or we believe we know everything, and the community doesn't know anything, right? We can't go. First of all, it's not true, and second, we need to know what they need in order to make everybody improve.
And and I'll stop here, but it just remind me I was visiting my nephew in Long Island a couple of months ago, and then I was jumping on, getting on the train to go Manhattan, and then one of the first time that I noticed that in the platform it said mind the gap. So just be careful the gap between the platform and the train. But because what you're saying, Gladys, talks about like we're so focused on to the next, getting on the train, doing the next thing, doing the project, providing care, making sure people are taking their diabetes medicine or the high blood pressure, and then we're not taking really a moment to say first who else are we missing, and then the other thing is like, okay, this is what is happening with this patient. More than just minding the gap in care, right? So minding the gap in platform, understanding like realizing that there's a gap here, and then what can I do about it? Instead of jumping in the train, we'll be moving on to the next patient or to the next community, really trying to fix that with this patient and then learn from that moving forward.
Because if you temporarily fix that gap, someone's going to come along and fall and trip eventually again. And so the sustainability is key. And so, oh my goodness, I can always tell when it's a good session because I'm exhausted after, and I'm like tired because it just the exchange is so interesting in a good way. We have time for one. We don't have the camera set up to capture you, but if you tell us your question, we'll repeat it. We have time for 2 questions. Anyone? Going once? I'm not going to force y'all. Going twice? 3 times. All right, no question.
So he has a
That's
question.
Oh, Sid.
Kind of going to a higher level, I guess, but where's the disparity with research and development? Like, for example, I was on the board with sickle cell, and I used to do a lot of advocating and a lot of meetings and stuff like that, and research was lacking. I broadened out a lot and involved myself in other areas and seeing that in a lot of Black and brown, including Hispanic, research and development was lacking. And so is there a disparity? Like, what do you see there?
You kind of touched on it a little bit.
Yeah.
Is there a disparity there?
It is. And one of our projects that we are actually planning is to improve representation of our communities in research. And so, and one of the things that I always hear, I'm using the A word always, is that I don't want to participate in research
Yeah, they
because I
ain't
don't.
poking me.
Oh yeah, no. I don't want to be an experiment. I don't want because you are just only using Black and brown people to do your experiments. But when you look at the data and you see the numbers and the representation of people, the big majority are whites. Very little number of African Americans, Black and brown. They are not there. They are not represented in our research. And this research, for example, some medication gets approved without having the representation of this people.
Remember, that was a little bit of the issue with COVID.
Yep.
In one of the first iterations of the vaccine, they were really going out and recruiting and saying, basically, we need Black people to come and be a part of research. Because if you get medications and stuff that don't have that filtering, for lack of better words, or testing, whatever, with the multiple, makeups that we have in DNA, and I want to make one point I learned about too before we go. The medicine, this is maybe why in the worst case scenario, let's say another disease or another medicine, and there's not a lot of people in the research, Black people in the research development of it, when the medicine gets approved and you find a lot of adverse impacts or reactions in Black people, the reason why. So I'm saying that to make the case that when, maybe, well, I ain't gonna commit us to nothing, but when there is a reputable entity or entities that look like you and I and folks that are listening, participate in those research studies, because you don't know the impact that adding in our responses into the overall findings. I forgot the term when they talk about findings about research. When they present them, it's good for us to be a part. We'll close with this. One of the things that I learned some years ago is while there are some folks that don't want to have offspring and children outside of their race, I had learned some years ago when I was at one of the Partners Related Hospital, one of the members of the network, that it's actually sometimes a good thing of I don't know how to properly say it, not mixing of DNA. You know where I'm going. I'm maybe not saying it right, but there's the different benefits that somebody explained it in a proper term. You know what I'm trying to say. that they're the benefits of I want to say not interracial or whatever, but certain diseases and certain DNA makeups may help fight. You know what I'm trying to say?
I know what you're trying to say.
Yes,
I mean, we do
please.
know that, like, sort of, when it comes to the gene pool, sometimes
That
we refer
may be
to,
yes.
there are diseases that may exist in certain racial groups and whatnot, and if offsprings are only from that same pool, you're likely to perpetrate that same disease
Yes.
over and over, because a lot of diseases will express themselves. We sometimes say expressive sort of genes will happen if it's both sort of sets of genes from both parents are the same. So you will have that, versus if you have someone from a different gene pool that may not have that, that could actually be the one that is dominant that ends up being expressed. And so there is sort of like, this is funny because I was watching one of my kids' shows about animals, and this is something they do often. I didn't realize that they were importing, zoos were importing pandas from other parts of the world to actually have mates for their pandas so that their offspring would not carry on the same sort of bad genes in a sense, to put in lay term.
In
And
other
sort of
words,
end up
if you mix things up, that can sometimes protect you from certain diseases.
from certain diseases, exactly.
With that being said,
I don't know how we got there, actually. That's a really
because
interesting question.
When you were talking
but
about,
that is-
when you were talking about early on about, we're all sort of a melting pot now, I immediately thought about that because there
I
is a
see.
medical gene pool benefit to some extent of that. So DEI is, but interracial love and yes.
You should be careful what sound bites we're giving you.
Exactly.
See, that's one of the things about going live. We can't edit.
We-
Listen, let's give our guests a hand this evening. Let's give them a hand for being with us. Dr. Claudia Lambre, Dr. Gladys Patches, Dr. Kareem Davila, and Dr. Efren, Jesus. Flores.
That's-
I almost conceded Outlook, and I'm like, I forgot that quick. Thank you, everybody from the audience that's here.
Thank you.
And we appreciate you. If you're watching and those that are here now, save the date of Saturday, October 1st, from 10 a.m. to 2 p.m. We're having a health fair right up the street. Hopefully, you guys can come out or just come and talk, whatever. I really enjoyed this. Dr. Lavra, we got to do this again.
We'll have to
Like
do
we
a part
did
two.
school.
Part two.
Yeah, yes, okay. That is cool.
But
That
I
is
know we skipped a whole part of this
Yes, so
conversation.
about
Talk about the impact of culture on medicine.
the impact. Well, we talked
Just,
about
we
it a
can
little
certainly-
bit, but we
did,
kinda,
yeah, right.
we kind
I
of
know.
go in the organic space because I think Kareem
There's so
started.
much.
Gladys
There's
started
so
it.
much
floor
to
was-
talk about.
So we can have part 2 and 3.
There's so much we can
Sure.
have. We can have a whole conversation and as well talking about the difference between a disparity and an inequity.
Inequity.
Yeah.
All right.
Leave you with that teaser.
For
That's
next
the
time.
cliffhanger. Yes, yes.
Tune in next week for
Yeah.
our next episode.
That is good. That is good. The next date that we are scheduled to do a live recording
Don't
will
forget
be
to
October
promote
7th.
their
I was
talks
going
as
to
well.
ask and close out with that. October 7th is the next time we'll come together. I don't know if it would be this group, but keep that date, save that date, Thursday, October 7th. This will air again on Tuesday morning at 9 a.m. And so if you came in late, you can watch it again. And please share with us the telecast on El Mundo and when when there's a, because it's a paper, El
Planeta.
Planeta is a paper. So
Yes.
It's online also.
it's online.
It's
So
both, it's both.
please share the information where people can go look and also see you in the, tell me how to say the minute again, something minute
El
moment.
minuto de salud. Minuto de
And say
salud.
it slow, say it slow.
It's the Puerto Rican in me that talks fast. I
Okay.
cannot. Unavoidable.
Okay, we'll do
Yeah, unavoidable.
El
minuto
minuto
de
de
salud.
salud. El minuto de salud.
There you go.
There you go.
That's better. Thank you.
Y'all know I can go out and sometimes people walk up and say habla español. And I'm like, un poquito.
And
Please
then
share
there's
with
no
us
Quito.
where folks can watch. Where can they watch?
Oh, every other week on
It's in
El
El Mundo.
Mundo.
El Mundo.
It's the segment.
El Mundo Boston, yes. That
El
is
Mundo
Mundo
Boston.
Boston.
The segment is called La Hora del
La Hora.
Café.
La hora de café, the coffee hour.
the coffee hour. That's right.
I like that.
You're gonna be speaking Spanish after this session.
Listen,
Too.
when I work,
We're gonna call you Jaime.
y'all are taking me back to some times in middle school when I didn't like Jaime, and I'm being triggered right now. I'm messing. Off camera, I'm gonna tell y'all about Spanish class. But no,
So is
seriously.
this first and third every other?
We are
How
trying
do
to do
people?
it every Wednesday. So it happened today.
Okay.
Next week we are having Recovery Month, and it's at 7:15 a.m.
7:15 a.m.
every Wednesday
And that's in Spanish.
in Spanish.
Okay.
So for anyone who Would
I think it
prefer
has
it.
subtitles. I think.
And it's recast on YouTube.
YouTube.
We have folks from the equity office that are here and some folks in the audience. And so shout out to Natalie Johnson, who's part of Dr. Betancourt's team. And also, while I'm naming names, Connor Markell and Leah and maybe not in Office of Equity, but just folks that work at MGH that I've been involved with the past year. October will be a year.
Cindy.
Cindy. Oh, Jesus. I'm going to get in trouble. Cindy Diggs, who was very instrumental in I want to say 2019 or 20 before COVID hit. And you got to meet Dr. Betancourt. And so definitely Cindy. And I got to celebrate this guy here I think he deals with me the most in this collaboration. Even more than Cindy. So Dr. Labrie, appreciate you. So that's it for us. We will see you as far as the Java with Jimmy World. Today's Thursday. We will see you all on Tuesday. No, Monday I'm in flight. Tuesday at 9 a.m. On Java with Jimmy. Thank you all for tuning in this evening, and we will be in touch. And if you're on Twitter, we've tweeted these folks. Go follow them so you can see what they're tweeting about and advocacy and sharing information. And thank you all for tuning in this evening. Walk, hit that end button.
Thank you.
And let us know when.